Good day, everyone. My name is Glenn Pierce. I'm the Vice President of Medical for the World Federation of Hemophilia, and it is my pleasure to invite you today to an overview of the WFH Treatment Guidelines, the third edition, which has just recently been published. So I need to go over a few housekeeping items. When you join the webinar, you'll see two audio options. You can listen by phone if you choose to. You'll just need to dial in on the phone. Or you can continue to listen on the computer, so your choice. All of the audios will be muted, so if you've got questions, please use the chat box and list your questions out. We will be compiling them, and we'll go over as many of the questions as we can toward the end of the hour. We'll also be recording the webinar, and it will be available afterward. We're going to begin today with two brief audience polls. First of all, we're interested in knowing more about you. Please select your response to the poll question now. Okay, so it looks like about half are healthcare providers and about a third are industry, and the remainder come from other places. So that's good to know. Our next poll question: which region of the world are you from? Please select one. A little more than half from North America, and about a quarter from Western Europe, Eastern Europe, or Russia. So these are my disclosures. I work with a number of gene therapy companies, both in and out of the hemophilia space. I want to give a little bit of perspective on the guidelines. This is our third edition. We published the first edition in 2005. Second edition about 7 years later, 2012, and now our third edition. And with each edition, we have gradually increased the rigor of the guidelines that we're developing, so that at this point, each of the chapters now in the third edition is supported by a full systematic review and an Delphi consensus process that has resulted in 344 practical recommendations. This is the front cover of the third edition of the guidelines, which were headed by Alok Srivastava. They included about 50 experts, both healthcare providers as well as some expert patient panelists as well. This time we had an expert methodology leadership team, and they guided us through the process for developing the consensus guidelines as well. And we've got some early endorsements of the guidelines. Our third edition contains 12 chapters, and we added specifically 6 new chapters to the guidelines in this edition. I've listed here where you can source the guidelines online. They can be sourced directly from the Hemophilia Journal, or they can be sourced from the WFH, which will then take you to the exact place in the Hemophilia Journal to be able to download them. So I want to give a little perspective, too, on hemophilia. We recognize well that hemophilia is a global disease and that there are a lot of disparities in care and in treatment around the world. We also recognize that as far as treatment goes, 60% of the world, which is the low-middle income countries and the low-income countries, use only 7% of the product. And so as we look at these differences in treatment practices, we still need to keep in mind that the principles of care are universal. And if we can adopt more of the principles of care, we have a number of publications over decades now that demonstrate that we can decrease morbidity and mortality, even in lower resource countries. And so those are the principles behind developing the guidelines. In the higher resource countries, we also recognize that care is not uniform and treatment is not uniform. We have a lot of evidence in the literature on that as well. And so developing these guidelines, even for the higher resource countries, becomes important to try to standardize therapy, standardize care, and improve not only the quality of life, but long-term outcomes for individuals with hemophilia. And I think we've been able to establish through the earlier editions of the guidelines, I think the second edition has been downloaded over 1 million times, that we can use data as well as consensus to make a difference in developing and in using these guidelines as resources. What we're going to focus on today are 3 of the chapters in the guidelines, and we have 3 experts to talk with us about those chapters. So it'll be hemostatic agents, prophylaxis in hemophilia, where a lot of changes have occurred over these last 10 years or so, and inhibitors to clotting factor. So who are our experts? They're listed here: Steve Pipe, Margaret Ragney, and Manuel Carqueo. I'm going to go ahead and introduce our distinguished panel all at the same time, and then we'll just flow into their talks. So our first speaker is going to be Steve Pipe, and I'm pleased to introduce him. He's a professor of pediatrics and pathology and the Lawrence A. Boxer Research Professor of Pediatrics. He's the pediatric medical director at the Hemophilia and Coagulation Disorders Program and the director of the Special Coagulation Laboratory at the University of Michigan. He also serves as the chair for the Medical and Scientific Advisory Council for the National Hemophilia Foundation. Our next speaker will be Maggie Ragney, and she is Professor of Medicine and Clinical and Translational Science at the Vascular Medicine Institute in the Division of Hematology Oncology at the University of Pittsburgh. She also serves as the medical director of the Hemophilia Center of Western Pennsylvania, based in Pittsburgh. And then finally, our last speaker, Manuel Carqueo, is the medical director, is the clinician investigator and the hematologist in the Division of Hematology Oncology and the senior associate scientist at Sick Kids Research Institute. He's the professor of pediatrics at the University of Toronto. He also directs the Hemophilia and Bleeding Disorders program at the Hospital for Sick Children in Toronto. So with that, the next slide, and I'm pleased to introduce Steve Pipe to get us started. Steve.
Well, thank you, Glenn, and welcome to everyone. So glad you had the opportunity to participate in this webinar. These are my disclosures. I have provided consultation to a number of the companies that make existing and pipeline products for therapeutics for hemophilia. So I'm going to be presenting updates to the hemostatic agent section. I'm presenting this on behalf of the co-authors that are listed who all helped to formulate these key recommendations. This covers general recommendations regarding hemostatic agents. However, recommendations involving hemostatic agents are actually found throughout the other chapters as well. I've decided to focus on updates to this section that involved corroboration of prior guidelines, that involved incorporation of new clinical tools, and those that still have some unresolved controversy. Now, to set some context and some practicality for these guidelines, I'm going to use some case studies to help frame these. So our first case is Liam, and he's 9 months old. He has severe hemophilia A. He was diagnosed at birth based on family history. He had a uncle and grandfather that were affected. No factor VIII exposures to date. He started to show more bruising and hematomas over his extremities now that he started crawling. And the family is ready to consider initiating prophylactic factor VIII replacement therapy. So the question is which products should we be starting? Recombinant clotting factor, plasma-derived, or starting him on a non-factor replacement therapy, emicizumab. So our first recommendation here is that for patients with hemophilia, the WFH actually does not express a preference for recombinant over plasma-derived factor concentrates. The choice between these classes of products really must be made according to local criteria that includes availability, cost, and patient preferences. That's actually been the stance in the U.S. as well, and I suspect that that's how many of our patient and clinic interactions go when they reach this decision tree and starting a young patient. And this really remains consistent with prior WFH guidance as well. Our second case is James. He's 16 months old. He has severe hemophilia A. He was diagnosed at birth after a bleeding circumcision. And he presented at 4 months with intracranial hemorrhage, and a port was placed for regular infusions. He developed a high titer factor VIII inhibitor and had 1 year of attempt at immune tolerance induction, but his inhibitor remained refractory. And the family really is no longer willing to continue in an intense infusion schedule to this end. So the question is how should he be managed now that he is deemed to have a refractory factor VIII inhibitor? So the recommendation for this section is that the WFH recommends that patients with hemophilia with an inhibitor should be considered for regular prophylaxis to prevent bleeding events. There was full corroboration with this recommendation, which really serves to close the outcome gap for those with inhibitors to those who are on prophylaxis without inhibitors. Now, furthermore, for patients with hemophilia A with inhibitor, the WFH recommends that emicizumab should be used for regular prophylaxis. Now, in hearkening back to our previous case, there's a remark in this section that also addresses emicizumab, where it indicates that for patients with hemophilia A with no inhibitor, the WFH recommends that emicizumab can be used for regular prophylaxis. So the panel did not feel that there was sufficient data to support that emicizumab should be used for regular prophylaxis over traditional replacement factor VIII therapy, but it certainly can. And specific emicizumab recommendations can also be found across multiple other chapters. Our next case is William at 8 years of age. He has severe hemophilia A, and he's been on primary prophylaxis since infancy using a standard half-life factor VIII administered every other day. And despite an aggressive regimen, he still has had occasional breakthrough bleeds, and the family is actually struggling with maintaining adherence to this rigorous schedule. So the question is, would he benefit from an extended half-life product? And if so, what regimen? How to evaluate his outcomes going forward? And does it matter which type of extended half-life factor VIII, meaning what mechanism of action that extends the half-life of the factor? So the recommendation is for people with hemophilia A receiving factor VIII concentrates who would benefit from optimization of prophylaxis, the WFH recommends individualized pharmacokinetic monitoring. And then in the remark, it indicates a classical approach to determining individual pharmacokinetics. And the panel felt that there was sufficient evidence that this is how patients with hemophilia B should be managed as well. Now, the panel also recognized the sizable work in recent years on the application of clinical tools for advancing an individualized pharmacokinetic monitoring approach, particularly with the aid of population pharmacokinetic tools, some of which now have regulatory approval. And the clinical utility really supports its application for hemophilia A and hemophilia B. This recommendation says patients with hemophilia who are transitioning from standard half-life factor concentrates to extended half-life factor concentrates would typically require decreased dose frequencies, but extended half-life products may also be used to maintain higher trough levels to optimize prophylaxis. And pharmacokinetic guided dosing, as per the prior recommendation, provides for more individualized prophylaxis. So the panel recognized that EHL factors offer some distinct advantages to reduce the burden of the frequency of prophylaxis, but they may also be used to maintain higher trough levels in order to optimize prophylaxis in specific patients. And the availability of population PK tools that include EHL factors now can really assist this application. This is the area of controversy. So for patients with hemophilia A or B, there's no evidence for any clinical safety issues in persons with hemophilia in order to recommend a preference among the various mechanisms of action. For example, pegylation, Fc fusion, albumin fusion, used to extend the half-life of the factor concentrates. So this was actually the source of much discussion because of disparities in regulatory approval between some countries and also an absence of observations at a preclinical level that are consistent across all mechanisms of action. So there was enough agreement that based on clinical safety endpoints to date, there was no evidence sufficient to recommend a preference among these different strategies to extend the half-life. And there are clearly monitoring issues and challenges in interpreting clinical correlations with specific plasma levels, and those issues still remain to be elucidated going forward. So thanks for that opportunity to give you an introduction to the 2020 updates from the hemostatic section. And so now I will turn it over to my colleague, Dr. Ragney,
Thank you, Steve. I'm delighted to talk with you about guidelines for inhibitors. These are my disclosures. They have to do with research funding and advisory board work with clotting factor and gene therapy companies. So I am speaking on behalf of a wonderful committee that I worked with to try to evaluate and come forth with guidelines for inhibitors to clotting factors. Next slide. So the disease burden among patients with inhibitors is significant. They have more serious bleeding and complications, more allergic reactions, higher rates of hospitalization, greater treatment costs, and higher mortality than non-inhibitor patients. So what's new? We certainly have some new non-factor agents that affect many of our guidelines on bleed management, inhibitor screening, immune tolerance induction, surgery and invasive procedures, and product switching. And I'll just talk a minute. Product switching is not a source of new inhibitor formation based on an increasing number of manuscripts and publications. So we'll start with clinical case 1. This is an 11-month-old with severe Hem A who develops large gluteal hematoma and other hematomas over the past week. He's been on demand with a recombinant factor VIII for a target right knee bleed, but it is poorly responsive to his usual recombinant factor VIII. There's no known family history of inhibitors, but a 3-year-old cousin who also has severe Hem A. At the end of the visit, lab tests are drawn, and he has a hemoglobin of 11, factor VIII less than 0.01, and a new inhibitor, anti-8, 12.0 Bethesda units. This is a high-responding inhibitor because it is greater than 5, and we would expect an anamnestic response if more factor VIII were given. His family asks how to treat him now that he has an inhibitor, and should his cousin also be tested. So these are the guidance for bleed management and inhibitors. Treatment is based on inhibitor type, whether it's a low responding, less than 5, or high responding, greater than 5 Bethesda units. And what you can see in the top boxes on the right is the high responding inhibitors, which he has. So for bleed management, we use 7A or APCCs. Factor VIII can be used, but only when that inhibitor has come down a significant degree. It will still be high responding, so you would have to monitor to see when that anamnestic response would occur and no additional factor VIII could be given. And what about screening for inhibitors? To the point of his cousin, after initial factor exposure, one screens every 6 to 12 months and then annually. So this patient, if he has been treated, then he would clearly need to be screened. We also do screening for a number of other issues, including poor response, recurrent bleeds despite adequate placement, before surgery, and for postoperative bleeding. So this same case is continuing. The bleed resolves. And so you introduce the concept of immune tolerance induction with the parents. They ask, what's the most effective approach? They want to know, is a port needed? They recently attended an inhibitor summit, and they met several families who've really had a good experience with emicizumab. So they decide to switch to emicizumab. But they want to know, if they switch, will it rid the inhibitor, or can it come back years later? And of course, we do not know that answer. We'll need years later of studies to figure it out. But how would they treat bleeds if they switch to EMI? So here are the guidance with regard to immune tolerance induction. There is no preference for recombinant factor VIII, plasma-derived factor VIII, or recombinant factor VIII FC. There's a success rate of about 70%. In small observational studies, the FC factor VIII may actually reduce inhibitors at a faster rate, but that is really only in a small number. We need to see more. Whatever factor VIII is used, current dosing is 100 units per kilogram daily, and the way we monitor success is with a persistently negative titer and a recovery greater than 66% and a half-life of over 6 hours. Failure is defined as the failure to achieve ITI within 2 to 3 years. And general guidance is that all inhibitor patients should undergo a trial of ITI. Data on the impact of extended half-life products is really limited, but after successful ITI, factor VIII prophylaxis should be initiated. Non-factor therapies may actually reduce disease burden. They're simpler to use, such as emicizumab and the sub-Q route. Use of non-factor therapies in ITI itself, however, is not established. Now, what about bleed management and emicizumab? Hemophilia A patients on emicizumab with high responding inhibitors in the right column, 7A is preferred over APCCs because of the risk of thrombotic microangiopathy, which has been reported in patients who receive APCCs while taking emicizumab. Close monitoring is really recommended in patients with thrombosis risk factors, such as previous VTE, obesity, smoking, chronic infection, and inflammation, and caution should be applied in discussing and planning for such patients to use emicizumab. Our case continues with clinical case 3. The child's maternal uncle is a 43-year-old man with severe Hem A who actually did have an inhibitor of 5.7 Bethesda units, but was unknown to the family of the first child. He was begun on ITI 2 years after inhibitor detection, but was refractory, not surprisingly, to ITI after 2 years. So he has been taking 7A for bleeds. Now he has painful arthritis of his right ankle, and the surgeon indicates that he needs ankle fusion surgery. His most recent anti-8 was 4.5 Bethesda units. He knows his nephew recently started emicizumab, and he wants to switch, but he first wants answers to a couple questions. Can he switch to emicizumab, or should he wait until after surgery? Once he switches, will he have to take 7A for bleeds? So our guidance with regard to surgery and invasive procedures will, again, looking at high responding inhibitors, requires us to determine factor coverage, bypass, and follow-up as usual. Now, in the first row, we're looking at a standard hemophilia A inhibitor patient not on emicizumab. For a high responding inhibitor, we would recommend 7A or APCCs, and if that fails, to consider a sequential use of those drugs. However, I would suggest that we are careful in whom we use sequential bypass because there may be greater risk for thrombosis if they fall into thrombosis risk categories such as obesity, hypertension, and so on. Now, next slide. If we look, however, in patients who are on emicizumab, 7A would be preferred over APCC at the time of surgery. So a patient taking emicizumab would continue that during surgery, and 7A would be used at standard doses, but would be tapered over a short period of time, and emicizumab prophylaxis would continue. Immune tolerance induction for those who are refractory or naive could include emicizumab prophylaxis, and it's recommended over 7A because it's more effective and it's simpler to use by the subcutaneous once-a-week dosing. I would also point out ITI should be initiated immediately after detection, which is a change from previous recommendations to wait until the titer fell below 10. So how should bleeds be managed during ITI? In patients with high responding inhibitors, 7A or APCCs could be used, but if a patient is taking emicizumab, 7A would be the preferred drug. If there is low titer inhibitor in a high responding patient who is now fallen below 5, factor VIII could be advised. So in summary, all patients with inhibitors should undergo a trial of ITI. Data on extended half-life products are limited. After successful ITI, factor VIII prophylaxis should be initiated. For hemostasis during surgery in inhibitor patients on emicizumab, 7A is preferred. Bleeds that occur while a patient is on emicizumab would be managed with 7A. Non-factor therapy prophylaxis can reduce disease burden, and use of non-factor therapies in ITI is not yet established and will require randomized controlled trials. And I'd like to turn the program over to my colleague, Dr. Manuel Carcao at Hospital for Sick Children, Toronto.
Well, thank you, Maggie. And I will now do the final presentation. Here are my disclosures. Here was my team that worked on developing guidelines on prophylaxis in hemophilia. As you all know that are on this call, hemophilia is a lifelong severe bleeding disorder. Without regular factor infusions, referred to as prophylaxis, persons with hemophilia, like these two boys, will experience repeated bleeds, and that didn't work. So next slide, please. Not sure why it didn't work. So without regular factor infusions known as prophylaxis, patients with hemophilia will experience soft tissue bleeds, muscle bleeds, joint bleeds, and potentially intracranial bleeds. This would lead to destroyed joints, pain and disability, and in many cases, early death. But with prophylaxis, boys such as these, now I will mention that these two boys are not my patients, they are from the internet images, but they may have hemophilia. But with prophylaxis, boys such as these do not have to experience such things as I just showed you. Prophylaxis with standard half-life factor has led in the last 20 to 30 years to huge decrease in bleeding. Shown on this slide are annual bleeding rates, so on the y-axis, and the bleeds are either joint bleeds or overall bleeds, and the patients are either pediatric patients or a combination of adult and pediatric patients in these three studies. And what's shown here are bleeding rates for patients treated on demand. Now, I'm showing you bleeding rates for patients treated on prophylaxis in these studies over the last 20 years. And clearly, there's been a dramatic decrease in bleeding rates of 80 to 90% on these studies. And with prophylaxis, with standard half-life factor, we have seen a huge increase in quality of life in persons with hemophilia, allowing such persons to participate in work and sports activities while at the same time protecting their joints. And as a result of these benefits that we've seen over the past many decades, this led our prophylaxis group to state the following, and this is really probably the most important guideline that we are indicating, that prophylaxis is standard of care. And it's not just standard of care in North America and in Europe, but it should be standard of care everywhere in the world. We wrote, and I quote here, for patients with severe hemophilia A or B, especially children, the World Federation of Hemophilia recommends regular long-term prophylaxis as standard of care. When prophylaxis is not feasible, episodic or on-demand therapy is essential treatment for acute hemorrhages, but it will not prevent long-term joint damage. We also go on to make the following remark. In countries with significant healthcare constraints, as Glenn referred to in the beginning of this hour, the World Federation of Hemophilia still advocates for the use of prophylaxis over episodic or on-demand therapy, but recognizes that less intensive prophylaxis may be used. In essence, what we are stating is that all forms of prophylaxis are better than on-demand therapy. We go on to make this following recommendation. The World Federation of Hemophilia recommends that prophylaxis be started early, so that early initiation of prophylaxis prior to the onset of joint disease and ideally before age 3. So clearly we are recommending primary prophylaxis. A further recommendation from our group was the following. For patients with hemophilia A or B with a severe phenotype, and that may include patients with moderate hemophilia, the World Federation of Hemophilia strongly recommends that such patients be on prophylaxis sufficient to prevent bleeds at all times. So going back to these experiences in this slide that I showed you a few minutes ago, from 1 to 2 decades ago, do these meet the current standards of the World Federation of Hemophilia in 2020 to prevent bleeds at all times? Well, as you can see here, on these intermediate dose prophylaxis regimens, patients are still experiencing almost 3 bleeds per patient per year. And I think that these days, most of us on this webinar would agree that that's still too many bleeds. And as such, that is probably not good enough. In contrast, the full dose prophylaxis regimen published by Marilyn Manco Johnson in the New England Journal of Medicine led to 1.2 bleeds per patient per year, which is probably okay. However, this is what, well, shortly. This is what full dose prophylaxis means with standard half-life factor 8. Shown here is 1 year of prophylaxis with standard half-life factor 8. Each circle that you see there represents a needle, an infusion of factor. That is a lot of needles, especially for children. This would be 182 needles, and clearly in children, even 1 needle is sometimes hard enough, let alone 182 needles. This is very hard. Next. So the result of this being so hard is that we as clinicians know that patients miss doses. No patient gets every single dose per year. Well, maybe there's a few, but very few patients are able to get every single dose. They miss doses, and every time that they miss a dose, they are put at risk of bleeding. So clearly, next, what patients need is they do need products that allow for less infusions. But suppose that a patient is able to do all of these needles, every single one, 182 per year. What do these patients achieve with such a very intensive prophylaxis regimen? Well, they achieve a factor VIII trough level of about 1 to 3%. And when normal is 100, 1 to 3% is clearly not that great. When you plot a 1 to 3% trough level on this well-known Dutch figure that many of you have seen, relating the annual number of joint bleeds on the y-axis to factor VIII activity in patients with mild hemophilia or moderate hemophilia, you will see that patients with moderate hemophilia who have levels of 1, 2, or 3% constantly will experience bleeds every year. So in these patients, if you let their trough level go down to 1 to 3%, it's not surprising that you would experience bleeds. So clearly patients need higher trough levels than what they've had in the past. So up until now, prophylaxis has been absolutely necessary, but patients have needed more. They've needed products that have less infusions, that allow us to give them less infusions, products that allow patients to attain higher factor trough levels, and especially for children, ideally products that can be administered non-intravenously, or a combination of all of these would of course be very good. So that brings us to one of the most important themes of these 2020 guidelines, a theme that very much distinguishes these guidelines from the previous guidelines that Glenn talked about, is that now with prophylaxis, we can do better. And I would add that we should do better. We wrote in the guidelines that now recognizing that with a 1% trough level, patients remain at risk of bleeding, most clinicians would prefer to target higher trough levels of more than 3%, 5%, or possibly higher than that. The theme that we can now do better with prophylaxis essentially relates to the use of extended half-life clotting factor concentrates and also of non-factor therapies, and with emicizumab being so far the only approved one. And as Maggie was telling you, these treatments, both extended half-life concentrates and non-factor therapies, allow us to achieve better protection than simply a 1% factor level. So what are the benefits of extended half-life clotting factor concentrates? Well, they either allow you to give less infusions, or they allow the patient to attain higher factor trough levels, or a combination of both, particularly for extended half-life factor 9, where you can certainly get both benefits. So extended half-life factor 8 allows the typical average patient to go from every other day infusions, shown on your left, to twice a week infusions, shown on your right. And with that, to not see any increase in bleeding. With extended half-life factor 9, the average patient can go from twice a week to once a week, and in fact, depending on the extended half-life factor 9, actually show less bleeding. Emicizumab, as Maggie was showing, can be given subcutaneously. And emicizumab has been shown in various studies that it results in a greater than 90% decrease in bleeds versus on-demand therapy. And it's given once a week subcutaneously. It can also next be given once every 2 weeks. And again, studies have shown a 90% reduction in bleeds. So what are the benefits of emicizumab? Well, they're shown here. They allow for less infusions, sort of higher factor trough levels. We all know that emicizumab is not factor. You don't get factor trough levels, but you get a certain percentage of protection that is more than what we used to get with 1 to 3%. And of course, emicizumab is non-IV administered. So we wrote in our guidelines for patients with severe phenotype hemophilia without inhibitors. Dr. Ragney talked about patients with inhibitors. This is without inhibitors. Prophylaxis with emicizumab will prevent hemarthrosis, spontaneous and breakthrough bleeding. So clearly this is an option. But we did make the following remark. Long-term data on patient outcomes with such an approach needs to be obtained. So this brings us to my final 2 slides. What is now prophylaxis? The fact that prophylaxis is not just factor anymore is really forcing us to address and update the definition of prophylaxis. So the old definition, as written in 2014 by Blanchette, my colleague, and others, is the regular intravenous infusion of the missing clotting factor, factor VIII in people with hemophilia A and factor IX in those with hemophilia B, given in order to increase the factor VIII or factor IX level with the intent of preventing or to prevent bleeding. And now the new definition, next please, is the regular administration of a hemostatic agent or agents with the goal of preventing bleeding in people with hemophilia while allowing them to lead active lives and achieve quality of life comparable to non-hemophilic individuals. Clearly, this definition is a definition that is no longer based on the intravenous infusion of the missing clotting factor. So these are our key recommendations in our section. The most important one is that prophylaxis is now standard of care, not just in North America and Europe, but everywhere. We can now do, and we should do better. And prophylaxis is now no longer just factor. So with this, these new guidelines and these new recommendations, I think that boys such as this, born with hemophilia these days, can look forward to a better life than they did in the past. And thank you for your attention. I'll turn it over to Glenn.
All right. Well, thank you very much, Manny and Maggie and Steve. I think we've gotten some excellent overviews of the new WFH guidelines. We'll now open it up for questions and answers. I see a question here on emicizumab. And maybe I'll ask Steve to start with that, but then open it up if Maggie and Manny would like to make any sort of comment also about it, because I think it may be a controversial kind of a question. So I'm wondering how you evaluate the risk of inhibitor development in a patient who is initially treated with emicizumab within a prophylactic treatment, so start emi prophylactically, and then patient has to have surgery or has major trauma, in which case they need factor VIII to control the bleeding. There's going to be an inhibitor risk that will be inherent with those kinds of traumatic treatments. So how do you think about that, and how do you prepare the patient for that sort of a situation?
Yeah, so there's no question that a patient who's only been exposed to emicizumab from early in infancy, we've changed the development or the timeline for exposure days to factor VIII. Those are going to be now protracted, probably over many years, actually. So if we assume that the immune system is still going to be structured so half of all those inhibitors are going to be within the first 10 exposure days, that may still not happen until the patient is well into school age, depending on their activity level and instance of trauma or surgery, like you mentioned. We do have assays where we can measure inhibitors going into surgery, and we can measure them even in real time if patients are developing them. One thing that is important to remember is the development of an inhibitor while you're on emicizumab for prophylaxis does not change your risk for breakthrough bleeding. All it changes is the choice of product that you would use to manage a breakthrough bleeding event. And so we definitely tell our patients, if they're on emicizumab, if they are using factor VIII, at home for occasional traumatic bleeds, if they have a bleeding event that does not respond to treatment, that is one of the key reasons why they need to call the center right away. So I don't think it's enough of a risk or concern that it should change the full treatment approach to prophylaxis with all of its benefits, but it does change the equation about the timelines and about how we think about managing that patient over the long haul and interactions with the HTC.
Okay, thank you. Maggie or Manny, anything?
I totally agree with what Steve said. I would only underscore how critically important it's going to be for randomized controlled trials to evaluate not only emergent bleeds and inhibitors, but also long-term. And we may need to do monitoring quite a long time to get answers to some of these questions. But I would also state that to do surgery in a patient on emicizumab, it is not a problem whatsoever. We just give emicizumab, try to time it at the time the patient has the surgery, and use factor VIII if they're a non-inhibitor patient, or 7A if they are an inhibitor patient, for several days at standard dose, and then slowly taper, and then continue the ME prophylaxis.
Okay, thank you. We have a lot of questions, so I'm going to see if I can get through them and ask you all to help me do that. The next question, I'm going to try to combine it. Is a question on extended half-life factor VIII, factor IX products, which we really didn't discuss those differences. And in line with that, so it's a question about discussing the differences in how does one think about the extended half-life factor IX products, which offer much more benefit in terms of half-life extension than the factor VIII products do. But also then the clinical safety of the extended half-life products. The question was, does that relate, what Steve said, does that relate to the extended half-life factor IX products as well? Steve, you want to start and then maybe ask Manny to finish up?
Well, if I understand what they're trying to get at here is, are there unique issues related to the mechanism of action that's used to extend the half-life of the molecule, whether that's pegylation, Fc fusion, albumin fusion? These are very different in their behavior. They can significantly change the volume of distribution in the patient and other pharmacokinetic parameters. And it also, in some cases, can change the assay choices for monitoring. So some of these products really cannot be monitored using standard, at least many of the standard clot-based factor assays, and may have to rely on chromogenic-based assays. So these switches should not be done without careful consideration of the availability for the patient to get access to appropriate assays, and also some understanding that, you don't make these switches and then just send the patient on their way. I think what we were trying to guide here is, if you're going to make that switch, you really should demonstrate that you achieved the pharmacokinetic change that you were expecting for the patient. There was actually a very good paper at ASH that was presented this year that came out of data from the WAPS Hemo group at McMaster to show that not all patients actually even get a half-life extension with these molecules. So the onus is on us with the patient to ask them to come back and evaluate the impact of that switch. And then the second criteria that I use with all of our patients when we make the switch is, pharmacokinetics is the first goal, but clinical effect is still of high priority. So I want to see that they are getting the clinical benefit from that pharmacokinetic extension as well.
Anything to add?
Yeah, the only thing I would add is that despite all the different mechanisms of half-life extension that exist, when it comes to factor VIII, we don't see a lot of differences between the extended half-life products in terms of their pharmacokinetics. There's a little bit of a difference, but not a lot of differences. That is not the case with factor IX. I do think it should be recognized that there is a substantial difference in the pharmacokinetics of the various extended half-life products. So they're not all identical to each other in any way. And otherwise, I would totally agree with what Steve said, that it's not a trivial thing to switch a patient. And we're still giving the first infusion or so, first few in the hospital. And of course, we do want to see what is the half-life extension that these patients are getting and how they clinically do. So it is important to follow these patients after switching for sure.
Okay. The next question is about the thromboembolic risk with emicizumab. I think that's a 30-minute talk, and maybe what I'll suggest is that there are 3 publications that are in press that are coming out any day now in the Journal of Thrombosis and Hemostasis that do take an in-depth look at this exact topic, and I think it's probably worth taking a look at those publications.
Glenn, maybe can I just, I wanted to go back to that first question regarding the risk of inhibitor development if you're on emicizumab. What, you know, we clearly don't know what will be the impact of patients being on emicizumab as a prophylactic agent from a very, very, very young age, perhaps as pups, and then only getting exposed to factor VIII in a setting of either a bleed or surgery, as opposed to in the past where they would be exposed in the setting of prophylaxis. So we've all heard over the years the danger theory, this idea that if you give factor in the setting of, you know, stuff happening to a patient, inflammation, surgery, bleeds, that there may be more inhibitor development. So we're going to have to follow these patients to try to answer that question. But I don't think we know what the answer is going to be in terms of inhibitor development.
Okay, thank you. Another question is about bioengineered cells, like artificial beta cells for the pancreas to be used to treat hemophilia. Maybe I can dispense with that by saying there's a phase 1/2 trial that is now underway using cells that have been engineered to produce factor VIII implanted into the peritoneal cavity, which should allow for production of factor VIII into the circulation. And so we'll see. It's very early stage, but it's a step in the direction of cell-based therapy. Is there a test to measure the level of emicizumab in someone? Can I get a short answer from one of you on that?
Yeah, we've been able to use calibrators, and we use a human chromogenic factor VIII that gives us a, if you like, it's a emicizumab activity, but I don't use it as equivalence. But it's a way that I follow the patients to make sure they're maintaining levels and if to look for inter-individual differences. There are some approved agents that use the emicizumab calibrators with a clot-based assay. It slows down the PTT and it returns linearity to the PTT prolongation. And when it's combined with the emicizumab calibrators, you can actually get an emicizumab level that way. So that's how I primarily have approached it in our laboratory. The reality is I do very few levels, not particularly useful for the vast majority of patients. There's very few clinical scenarios that come up. Where it becomes very important is when you're trying to determine adherence, particularly if a patient comes in with bleeding symptoms or needs to go to the OR abruptly or whatever. But the straightforward assay is a PTT. And if the PTT is not normalized, that patient doesn't have any emicizumab on board.
Another question is from a parent. Where can my child with factor VIII non-inhibitor obtain emicizumab? What I would say is it's approved in many countries, not all countries, and you should start with your hemophilia treatment center and discuss that with them. For Dr. Carcao, you mentioned that emicizumab decreased the annual bleeding rate in more than 90% compared to on-demand. So the question was, what is the annual bleeding rate on emicizumab prophylaxis? Maybe you could clarify that.
Well, it also depends on what kind of patients you've moved to emicizumab. Clearly, in the adult studies where you take patients who may be in their 30s or 40s or 50s and already have some damaged joints, and you put them on emicizumab, you're bound to see more bleeds than if you take pups or very, very young children who have pristine joints. So in the adult studies, you're looking at bleed rates of maybe 2 or 3 per year. And in the pediatric study, it was phenomenal in that it was much, 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 much less than 1 bleed per year. So it essentially means that most children will go most years with no bleeds if they start on emicizumab at a very young age. So it really depends on what the population is that you're putting on emicizumab.
Okay, thank you. A question about the lab guidelines and the role of the medical laboratory. Well, maybe I can answer that by saying we have an entire chapter in the third edition of the treatment guidelines headed by Steve Kitchen and a great assembly of lab directors that focus on all of the hemostasis assays. And so I would direct you to that chapter. A lot has happened in the intervening years, as you just heard from Steve, in trying to, for instance, assay for emicizumab. Another question for you, Manny. Could you comment on making prophylaxis as the standard of care in low middle income and low income countries such as India, where patients have accessibility and affordability issues in general?
Well, clearly it's not easy, and we need to have emicizumab. We need to have sort of access to products. Some of the things that I think are important is, as Steve mentioned earlier on, we don't necessarily favor recombinant versus plasma-derived. I think the best is, in a way, the cheapest and the one that is most readily available. So plasma-derived products can certainly be used in patients. Obviously, if companies reduce the prices of these things, that helps a great deal. Fortunately, the price of a factor, especially standard half-life factor, over the years has come down, so that's helpful. And then the last thing is that, as I mentioned earlier, any prophylaxis is better than no prophylaxis. And so low-dose prophylaxis and intermediate-dose prophylaxis, especially if you individualize it for the patient, and it does involve, in some cases, patients getting repeated doses in a week. They may have to get 2-3 doses every week. But if you do that, you can usually use lower doses given to patients and prevent and reduce a great deal of the number of bleeds that they have. And there's been many studies over the years from many countries. I can just name China and Thailand and Tunisia and many others that show that low-dose prophylaxis is maybe not as effective as full dose, but it certainly reduces the number of bleeds dramatically.
Okay, we're going to need to wind up in a couple of minutes. I'm going to try to get through two more questions at this point. One is a little controversial, and it asks about some of the disquiet about pegylated extended half-life products and why there is no preference expressed toward EHL products using FC fusion or albumin fusion. Who would like to take that?
So that's what our section really deliberated over, and it really, the consensus came down to that there are some variabilities in approvals between the countries, but we did not see any consistency in the preclinical observations in cell lines or animal models with specific mechanisms of action. And actually, there are no clinical safety signals that have been raised for any of the mechanisms of action. So we emphasized the choice was related to the clinical safety endpoints from the vast clinical experience with these agents and from the clinical trials. And we recognize the question marks that have been raised related to some preclinical observations, but with no corroboration on the clinical side. That's why we came down the way we did.
And then another part of that question was the process for updating the guidelines. And I can say that that I don't know yet. We are thinking about a living guidelines model where we would constantly update them, but we have not yet agreed on that. So stay tuned, please. And then maybe our final question is a recommendation now to have trough levels of 3 to 5%. And perhaps each of you can weigh in on that kind of a concept, regardless of whether there's a recommendation or not.
Let me just start. I think we always aspire to do the best that we can for our patients. We don't want our patients to have bleeds. As a pediatrician, if my patients have bleeds when they're 1, 2, 3, 4 years of age, those bleeds can have an impact for the rest of their life. So we try to avoid bleeds. And so if we can persuade the families and the patient to adopt a strategy with the use of extended half-life products and also with maybe not going once a week, because that would not be enough for factor VIII, that they would achieve higher trough levels to avoid all bleeds and to allow them to be fully active with very little anxiety about bleeding.
I would agree. Yes, I would agree with that. And I would just say that with higher levels, we can see better outcomes, as with some of our gene therapy trials. And it's a shame to limit the potential to avoid all bleeds and to have improved quality of life for all patients as much as possible.
Yeah, fully endorse that strategy. Although, any prophylactic strategy falls down if you can't adhere to it, you can't get access to the product, the patient can't do it. So it doesn't usurp the primary goal from that section, which is, prophylaxis is still the standard of care. So you have to do something. Aspirationally, if you can take them up to that next level, that's fantastic. But it shouldn't be the only goal.
All right. Well, thank you all. Let me move to the next slide, and at the same time, apologize for not being able to get to all of the questions. We have some great questions here, and so we will follow up on those. And so what you can hear from my colleagues, what you have heard from my colleagues over the course of this hour, is that a lot has changed between 2012 and 2020. We have just highlighted 3 of the 12 chapters in the new treatment guidelines. We have told you where you can find these guidelines, so I would encourage you to look there. And what you can see from just what we've presented is that we have a lot of changing practices in comprehensive care management. And that whole concept of comprehensive care is just so important. It's not just a matter of employing new agents to treat hemophilia. It's taking a holistic view of comprehensive care. And that's part of what, under Alaksari Vastava's leadership, we try to accomplish in these guidelines. We have newer agents that are moving us, as you've just heard from our panel, toward a bleed-free existence, which is a wonderful thing. But it's not uniform, and there are huge discrepancies, huge differences around the world, as Manny went into toward the end here. And that means that we still have a long ways to go to have more equitable treatment for all individuals with hemophilia around the world. With that, I would like to move to the next slide and thank our hosts, the Centers for Disease Control, for this webinar series, the Hemophilia Federation of America for organizing this for us. And I would like to finish up by saying on February 25th next year, 2 to 3 p.m. Eastern Time, we will have another webinar, and this will be on the joint guidelines on the diagnosis and management of von Willebrand disease. We've had a lot of activity the past year and a half on developing a whole set of guidelines for von Willebrand disease between the NHF, WFH, the ISTH, and ASH. And so we have 3 eminent speakers that are going to cover that for us. Please mark your calendars. With that, I'll thank you all for all of your attention, and especially thank our panelists for the time they've given to develop these talks. It's really a terrific opportunity for all of us to work together and continue to promote the vision that we have for hemophilia, which is treatment for all. Thank you.